Hello, a lovely member zone. We had a wonderful tea and chat last night, which was fab. We had vets over from America, which was fantastic. So hopefully we're going to have a star-studded audience again today. I've got the awesome Dr. Samantha Lindley with me. She did a very, very thought-provoking lecture in the Chronic Pain Symposium. It was recording. She wasn't able to do Q&A during the event, but she offered up her time this evening to come and answer any of the questions that people posed during the event or after. So first of all, I'm going to let Samantha introduce herself. Please tell us a little bit about yourself, tell us about your journey, etc., and then we'll go on with the questions.
Okay, hi everybody. Yep, so I'm Sam Lindley and I've been doing chronic pain. I've been started with chronic pain probably in the early 90s when I started doing acupuncture. I was a large animal vet and went to learn acupuncture because a friend wanted to learn it. And then I started practicing on farm animals and farmers and my boss and anybody who lay still long enough. So I did that for a bit, and then I got sidetracked into animal behavior, as you do when you're a large animal vet. That's because I skived the animal behavior lectures. That's what happens. You need to be careful about what you skive because you end up doing it. And I worked with Dr. Roger Mugford, who some of you will remember him and some of you won't. He was very famous in his day. And although not a vet, he was very supportive of the veterinary profession getting involved in behavior because he felt that there must be a lot of clinical background to the behavior problems, although apart from some inkling about diet, he didn't really know what that would be, but he just felt the veterinary profession should be at the top of looking at behavior. So I was then doing lots of acupuncture and then I was doing behavior, and I realized that what my clients whose patients were getting whose pets were getting acupuncture were telling me in a positive way, i.e. positive changes in behavior, were what my behavior clients were telling me negatively. I'm going, oh, hang on a minute. Oh, there might be something in this. So I'm going, oh, so could all these things that they're talking about be to do with pain? I mean, we were looking at other things as well, like diet and false pregnancy, but that we discovered. But a lot of what came up was about pain. So that's how the two things came together, which is why when I originally started this, there was a little bit of, why is she doing chronic pain? She's not an anaesthetist from some quarters. Because, that's usually the provenance is that you start off as an anaesthetist. And I started with a very different background, but it was the acupuncture, which teaches you the skills with your fingers, but also, and this is fundamental with chronic pain, acupuncture has an effect on the limbic system. Its main brain target of manual acupuncture, that's without electrical stimulation, is the limbic system. It deactivates an overactive limbic system. In other words, caring about the pain, which is one of the most important things in chronic pain, is how our patients feel about it. If we can't cure it, which many, many times we cannot do with chronic pain, we have to stop them caring about it. And so acupuncture deactivates the limbic system, which is why I was seeing those positive changes in behavior with my acupuncture, and then linking that to my behavior patients, and then realizing over time that more and more of these cases, not more and more, just I was recognizing more and more of these cases of behavior were linked to chronic pain. And we now have a figure where it was poo-pooed at, no more than 5%. I'm going, I think it's a lot more than that. We now have a paper written by Mills et al. Quoting, and this is referred cases, and that's important, referred cases, but still 70 to 82% of behavior cases caused by pain, contributed to by pain, which is massive. And so that was how it sort of came together. And then teaching more and more acupuncture, and then teaching about chronic pain. So it all just came on a roll, really, from there.
I love that you said about that paper, because I think you will like this. With the recent rise in concern about young dog OA, so then you've got the Elanco funded studies that are done by Masataka, Enomoto and Lascelles. And they are very classically orthopedic, so it had been very lameness based, it had been very body posture based, they're drifting into your understanding, behavior. How are we going to identify these young dog OA cases? Because they're not overtly lame, or what are the other signs? And you must be quite happy to hear people talking about behavioural indicators of pain that are some of the freshest, the newest type thing.
Yes, they're obviously delighted. And when the Vet Metrica or New Metrica scale came out, of course, when I was involved with it, just in a tiny periphery, way back when they just started talking about words, just when they were talking about words that came into groups. And then I sort of dipped in and out of it for a bit. And then when Jackie Reed presented it, I went, oh my God, this is amazing. It's all about emotion. It's fantastic.
Yes.
This is great. So yes, but it still is pretty much the only scale that focuses on emotion and not on lameness and ability to walk and ability to run and ability to gallop and all of those things. Although some years ago we did, even the orthopedic surgeons, Dave Bennett in particular, was talking about behavior in cats. It was cats, the biggest thing you're going to see in a cat with arthritis, apart from an inability to jump, are changes in its behavior. So actually, in a way, strangely, because cat medicine and therapy is often a bit behind the canine stuff, actually, in a way, people got way ahead there with the cats, realizing, because of course cats don't like giving anything away. So you have to look at their behavior, because they don't usually go around, waving a leg at you and being overtly lame until they're the arthritis is pretty progressed. So you have to changes. So
there's a lot happening, isn't it? Like, do please tell people about your kind of journey with regards to teaching, establishing the Western Acupuncture Group, Longview, because I said something before we went live saying, I don't know how you've done it for so long, and the pushback and the disbelief and the no, you're not correct. Of course, they'd be lame if they were in pain. And now, you're globally teaching people, aren't you?
Well, I have globally taught people, yes. Yes, that's true. And it's great that people are recognizing there is still a little resistance, and there's a lot of things I hear in passing that people say in the pharmacy. I don't mean anything to do, I mean physically in the pharmacy at Glasgow. And it hit me one day when I walked in and I said something. I think I was doing that frustration thing about, why can't they see this pain? And I don't think you'll mind me saying it was Prof. Ramsey, who said, yes, but they're looking for orthopedic pain. Oh, it was first going, what? And then, of course, and this is what we have to remember, orthopedic surgeons are trained to look for orthopedic pain. They are looking for something that will justify them getting their scalpel out and doing something to that joint, which is irreversible in some ways. They need to be really sure it's that joint. So they are looking for orthopedic pain. The neurologists are looking for neurological pain. I don't mean neurological signs. They're looking for that as well. But they're looking for neurological pain that justifies doing something either very serious with steroids, other medication, or with their scalpel. Something that could be irreversible, could cause death, could cause paralysis. They have to be sure that their particular discipline, their drive is satisfied by what they see. And the problem with chronic pain is it often isn't. And that's why they get frustrated. And this is me supporting our orthopedic and neurological colleagues. They get frustrated with us going, it's painful. Can't you just find out what's causing it? Going, I cannot say that it's this joint. I cannot say it's this disc or this couple of discs. I can't justify doing something with that. And then, of course, if the communication isn't good, that leaves the owner in limbo.
Yes.
Going, well, they say there's nothing wrong. And you said that they were really painful. And going, So it's really important to prepare the owners that this is what the orthopedics are looking for. This is what the neurologists are looking for. If they don't find anything to do, great. That's fantastic. No surgery. That's a bonus. Come back to me, because what we then have to deal with is the chronic pain that your patient definitely has. It's not a failure of them, and it's not a failure of me. It is simply a rule out of what of the things that we're looking for, great. They don't need a hip replacement. Fantastic. I'll take it back into my care and we do our stuff.
Do you know what? I think I've just waited 10 years for someone to say that as kindly and eloquently as you have. I'm not buttering you up. I mean it, because we get, well, no, hats off to you too, because I would say probably within the top 3 questions that we get via emails, via messenger, is always, I sent a case in to the vet, they didn't see it as painful, and now the caregiver doesn't believe me, my client doesn't trust me, they think I've wasted their money, they think I don't know what I'm talking about. And that'd be a trainer, that might be a physiotherapist, and there's been a breakdown in communication. But what you've just described would be wonderful to achieve if all parties were respectful for each other's pain discipline. Instead of pain being one discipline, there's different disciplines within pain.
It's orthopedic pain, it's neurological pain. And what we have to remember as vets, we have to be humble and remember that we are pretty much trained to look at joints, and bones and spines. We are not trained to look at the soft tissue, to look at the muscle, to look at the subtleties of hyperalgesia and allodynia. We simply are not trained to do that in our veterinary training. But I don't think, but of course we're not told that we're not trained in that. So we go, well, this is what I've done. I've done the thing that I do, that I know I need to do in order to find pain, and there's no pain, and therefore there's no pain. So everybody needs to do some give and take and say, yeah, okay, so I might be wrong with that, or thank you very much for confirming there's nothing that you can see on the spine. Fantastic. I know I'm not missing anything. That's great. That's positive. Now let's move on and carry on. So I prime my owners over and over that there may either be nothing found, or if there is something found, it may not be thought to be significant. And then I'll say, look, I'll decide whether I think it's significant for what I'm finding, not the same. So I very much prime my owners to be supportive of the orthopedic surgeons and the neurologists, and say this is what they are doing. This is their discipline and they're skilled at it. We go with that. We go with what they're saying, but you might still need to come back to me for the following treatment. I speak to the orthopedist and the neurologist and say, if you don't find anything, please, just send them back to me,
and that's where things go wrong, I think, isn't it?
Because that can be a thing of going, well, we've got to say something, and quite often it's, well, it must be behavioural then, or there's nothing.
Or there's nothing wrong.
So you need to get in beforehand and say, please, if you don't find anything, I have this, this is what's going on with the client. This is very important that we keep on board here. And can you please just say there is nothing wrong for my discipline, nothing wrong that we need to do orthopedically, nothing wrong that we need to address neurologically. Can you please then send them back to me for continuing care? And that is.
Do you know what I'm going to get? I'm going to just somehow one day in the next 5 years get you to write me the sentence that you could put in like a referral report that gets that kind of interdisciplinary.
I think, unfortunately, it goes back to the old-fashioned thing of picking up the phone and speaking to somebody.
Yeah.
Because I think unless you speak to them, these things don't, because they're going to look at the, this is what we all skim read stuff. And I'm not, we all skim read it and we read the bits. You're going to focus on the clinical bits. You're not necessarily going to see that bit at the bottom which says, please send them back to me. But if you have a physical connection, well, that's way over the top.
Committed.
A verbal, that's the one we want, a verbal communication, because we forget about that these days. Everything's easier in email, everything's easier by text. Have a verbal communication. And of course, that's the great advantage I have. I'm incredibly lucky because being at the vet school, I can walk through the back, as we call it, through the back. Well, that's what I call it. And buttonhole somebody and talk to them and say, this case is coming to see you. Can you do and then can you send it back to me, or can you do this? So you try and make that connection beforehand, and then that saves a lot of trouble. And the other good thing is it gives them a way of going, great, all I need to do is go, nothing for me to do here, off you go, rather than going, well, I've got to say something now. I've got to say something definitive. There is, oh, it's probably behavioral, or it's this, or Sam's wrong, or she might want to say, or whatever. So so it's quite useful.
I love that. That's a really, really great, and it's similar to question 2, which we will come to. But if it's okay with you, I'm definitely going to promote those, because it is a common problem. It's so common, and definitely with people, be them a nurse or be them a vet that's just getting interested in pain management, or a physiotherapist, there's nothing worse for confidence when you refer something in because you want somebody else's support, you want their skill base, you want their experience, and they inadvertently say at the end of their time with your client, oh, there's nothing wrong, don't worry about it.
Yeah.
And it's the biggest blow to your confidence, isn't it?
And it is going to happen. And you just have to hope it doesn't happen, as you say, right at the beginning. Happen when you're long in the tooth and don't care so much and can take it and still gather the client back in to your fold. But it's the priming them beforehand that's important, but not in a negative way to set them up against the person they're going to, but just to say we're valuing what you're doing, what you're bringing to the party, and then then if there's nothing there, come back to me and we will continue the process.
Yes.
It doesn't always work. Of course, it doesn't always work. And sometimes there are personality issues because we're humans and we're humans talking to humans, and it goes wrong sometimes. But you can do the best you can. There was something else I was going to say there about that. Oh, yes. The other thing is a good tip. If you are a clinician who sees, or a trainer or a carer, and your professional trainer or carer or physiotherapist sees the dog or cat it's mainly dogs we're going to talk about, in a different context, then that can be very different from them seeing somebody in a referral centre taken away from the owner. The big thing that people think is that dogs are easier to examine away from the owner. A few of them are. Okay, a lot of them are easier to do things to when they're away from the owner, but to do the subtlety of a chronic pain examination is not easier in the part away from the owner. Most of the dogs are easier to do things to because they shut down, and so you do stuff to them. With chronic pain, you need a very relaxed patient, and you need time, and you need to be able to pick up really subtle things. And that doesn't usually happen in that kind of referral setting. So, and I'll often say this to my referring vets, because, obviously the owners are going, oh, why didn't my vet pick this up? And going, well, because they had 10 minutes. And, there are endless possibilities as to what could be going on here in 10 minutes. And the reason they sent you to me is because they know I'll triage you. And if you need to go to neurology, I'll say, and that's why they send you to me, who's a vet and who does chronic pain. So they know I'll pick that up. They didn't miss this. It's just that in a 10-minute consultation, and with this kind of, with the animal stress because they're expecting to be vaccinated or have their anal gland squeezed or whatever, they're tense, and you cannot do that for a chronic pain consultation. So that's another thing that you can say to owners that explains these differences.
I like that. And I think also if because we've been trying to focus on this interdisciplinary of don't get dejected by these things, keep striving for that interdisciplinary team, keep your ambition strong, is if you do have the advantages of looking at animal in a context that they're more comfortable, and you could take media, so you could take videos and photos, and you could get more information to supply your colleague with the best chance of success. That's a really good kind of relationship building exercise, isn't it? If it's just sending them a referral letter going, this is what they say, this is what I say. If you complete the picture with lots of media, it's a good way to start building bridges, isn't it?
It is. And the other thing is that you can also give them permission just to look at their bit. I often make the joke about, owners come in and go, oh, they need the dental and the hearts. And I went, but my bit's fine. And they laugh, like it's separate. Of course it's not separate. I go, but my bit's fine, so I'm okay. And they just laugh and go, yeah, your bit's fine. The pain's great. But if you can say to them, I would like you, could you please rule in or rule out joint pain as a cause of this dog's issue? You don't need to do anything else.
Yes, that's a
you
really
please
good point.
do this and MRI the spine so that I know I'm not missing anything that needs a more specific treatment. There is your clear ask. You're not asking them to do anything more than that. Now, that isn't necessarily that's what they'll do, but you can at least say, this is what I would like you to do, please. I don't mind if you don't find anything. I need to know, and you can be ever so humble, Mr. Copperfield. I need to know that I'm not missing, that this animal needs a hip replacement. Can I just make sure of that? What's your opinion about that? Value your opinion, and then you can, and then if you don't think so, I have told the client that they will come back to me and I will continue their care. So you need
I love
to make
it.
Clear.
I love that. There's so much
work, but if you just try and these different things, because if you just give an open-ended, they will think quite as we would. Oh, I've got to fix it. I've got to fix it. Oh, there's nothing to fix. I don't know. There's nothing for me to fix. Therefore, but I have to come up with an answer.
Yes.
The answer must be that there's nothing wrong, or they're making it up, or they're wrong, or they're overdoing it. All this pain stuff is overdone, and all the rest of it. Because there is a little bit of thought of that. There is a bit of thought that we're overdoing it, and we're not making it up as in we're making it up in some dreadful Machiavellian way, but that we don't know what else to do with these behaviour cases. Therefore,
so we're making it up as we go along, type thing.
Well, it must be pain, and that's not how we come to the conclusion of pain. We don't come to the conclusion of pain because we can't find any other reason for it. We come to a conclusion of pain because of many other factors.
Yeah. No, I think that's been hugely helpful, and I know that I'll be quoting this for many years to come. Right, I'm going to drag you into some of the questions. Some of them are going to be quite quick, and we can quite succinctly get through them. Others maybe more discussional. Question number 1: can changes in the joint before they are seen on X-ray be causing the pain?
Yes, I mean, the simple level would be things like microfractures, and simply, instability of the joint can cause pain. You don't have to see anything in terms of periarticular or bone changes or osteophytes before there's pain. So yes, there could be, but we also have to remember that just because there's a joint problem, all the pain doesn't come from the joint.
Yes,
Explain
that.
So ligament pain. So we've got pain in the synovial capsule, of course, which you can't see, and you're going to have pain in the ligaments, and then you will have and the tendons, and then you may have secondary muscle pain. So it has to be said, we don't know why this happens, but significant pain in a joint and in viscera and in other areas, but let's stick to joints, can set up these things that we call myofascial trigger points in the adjacent muscles. Those can be very painful, and if you have them, you may think you're getting nerve pain. They can be as bad as that. They refer pain a long way, they can spread pain a long way, and they can be significantly painful. So a jar to an unstable joint might set up a trigger point next to that joint, in the muscle next to that joint. So for example, the hip, it would be the gluteals, and then continue to give pain in that area, which for all intents and purposes will look like hip pain, although it will be hip girdle pain, hip muscle girdle pain. Mm-hmm. But there'll be nothing much to see on the radiograph, even though the hip and instability in the hip might have been the trigger for it. But if for some, let's just say you could block the hip, just the hip, which would be quite hard, you would still have that pain coming from the muscle, which would look like hip pain. So that's a complication for all of these things that we're talking about. Yeah. In that myofascial trigger points are not taken into account. So one of the reasons is certainly not the only reason when someone looks at a radiograph and says, well, they shouldn't be that painful. Of course, there is no there shouldn't be. They are.
Yes.
One of the reasons is that some of that pain may be coming from the soft tissues around the joint, and that pain can be screamingly significant and painful, very painful.
And I think that's a really good point to make, because I know that when I came out of university, there was this weird concept that had become established. I don't know why, that, well, bone pain will be really bad pain, you know, and nerve pain, yeah, that'll be really bad pain. And I don't remember.
It's just
really.
muscle. It's
Yeah.
just muscle. It's just
Yeah.
muscle. Have you ever had muscle pain? It's really
But I don't think I got taught that. I don't think somebody sat me there and said that. I think there was some.
Because the concept of myofascial pain, so muscle pain, yes, it hurts if you tear a muscle, it hurts if you've got a hematoma in the muscle, but I think it's because it mostly doesn't require surgery, and it'll get better with rest, and it's that achy thing that you get. But myofascial pain can feel like somebody is twisting a hot screwdriver in your muscle, and it can spread, a long way. And it can feel like nerve pain. There's a whole lecture on mimics of radiculopathy, quite a lot of which are myofascial trigger points.
Oh, really?
So, yeah, Mike Cummings, who designed the acupuncture course with me, who's a medical director of the British Medical Acupuncture Society, took up a paper which was mimics of radiculopathy, and then added all the trigger points that could do the same thing for all the spinal segments in humans. So we have a look at that in one of I think we did it in last year's symposium, actually. Not your symposium, our symposium.
I know, sorry. I'm so sorry.
We can all have symposiums, don't have a patent on the word. And Mike, Dr. Cummings, had a lovely paper about this woman who had surgery on one arm, and she needed the same surgery on another arm, didn't want it because the pain she was getting from the operated arm was so severe. Everybody assumed it was neuropathic. The pain was so severe, and she was on carbamazepine and all those really heavy neuropathic drugs. And he looked at this arm and he found one trigger point, pressed one trigger point, and it absolutely mimicked her pain. And he treated that, and that was that.
It's amazing, isn't it?
He does one of the cases in the human course where this guy had watering eye and nose running, which was big alarm for neurological pain. He'd had brain scans, he'd had all sorts of stuff. He was on heavy neuropathic drugs. He was still really painful. Trigger point in upper trapezius.
No.
Creating a trigger point in his masseter. And the pain was so bad, it was making his eye water and it was running down his nose. And that's how severe it was. But it was so severe, people were putting him on heavy, which don't work for myofascial pain. The drugs don't work very well for myofascial pain. So it can absolutely be incredibly painful.
So a secondary question to that. So now that we've kind of done can changes the joint to be seen before there is pain, and we've gone on to myofascial as being one source that isn't imageable, do you think, having seen changes in behavior through the vet sector, having seen, the rise in physiotherapy, do you think we'll ever get to a point where there are going to be people in every clinic that have myofascial palpation capabilities, and when an animal is presented, they can do it in-house, have a greater kind of secondary approach? We've had in for x-rays, we haven't found what we expected, now we're going to go and see to the in-house practitioner that is more. Do you think it will happen?
Well, we're getting there. I mean, God, I've been teaching it since for 24 years now. And there are many, and most of the people who come on the acupuncture course say that they now examine patients differently. In addition to what they did, not completely differently, in that they now do additional things and they find so much more in terms of that and in terms. So through the people learning acupuncture, that'll happen. And then, but there will all, acupuncture is never going to be learnt by everybody. I mean, that would be nice, wouldn't it, when I rule the world? But it would be nice if we could train people. So the physiotherapists and the rehab people are trained in myofascial pain. But I think that sometimes that is lost in the language when it's communicated to the vet, because the physiotherapists do use quite different language, and it can be lost a little bit. In what happens. So there's a lot of stuff that you get from a physiotherapy report, and and I don't, people just don't have time to necessarily say, oh, what is that individual thing? What's that individual thing? So it would be really good to get people trained in being able to find not only myofascial pain, but also being able to identify hyperalgesia and allodynia, i.e. the signs of central sensitization, because that's the massive thing with chronic pain. Yes, trigger points, absolutely. But the big thing is allodynia and hyperalgesia, because that's where a lot of things I see many patients who've had absolutely the right medication, but not necessarily at the right time or in the right order or at the right level. And so the pain is still up here. Sorry, the pain's still up here. The medication's doing exactly what it's supposed to do, but the pain's already up here. So it came in too late, too little, too late. So that is probably a bigger cause. I mean, obviously I love myofascial pain, and not in personally, in terms of a discipline and finding it, and it's very important. And certainly we can find pain in our patients that our colleagues can't find, which annoys the hell out of them. And but the signs of central sensitization are probably, for our chronic pain patients, more immediate and more important.
Yeah, and could we possibly say more of a welfare concern? I think you probably know that I was very motivated to set up CAM with that hideous dull ache in yourself, knowing how many you've missed, and then thinking about the dogs that you brush past in the waiting room and they sidestep, or you go to palpate them and they flinch away from you. And I look back on the 11, 12 years I'd been a vet before I knew any of this, and I kind of recoil at how many I will have missed. So yeah, would you classify them as like a pressing welfare concern?
Oh yeah, definitely, because a lot of them, most of the chronic pain patients I see, and obviously I'm only seeing a small proportion, but there'll be many that don't come to me, have central sensitization, or probably a better term is an expanded. I think I used this in the lecture, and I think this was Mike's term. I don't know where he got it from, but it's such a great phrase because it gets around the whole: is it central sensitized? Is it secondary? It's an exaggerated and expanded pain field.
That's like that.
Expanded and exaggerated pain field. That's what we have. That's exactly what it is. Doesn't matter whether you want to call it central or secondary sensitization or what the thing is. It's a bigger pain field than what they started with. You can start off with one little and it ends up like this.
Do you know, that's so good, because it's a bit like behavior, where some people get inhibited saying anything just because they don't know whether they're going to use the right terminology. And when I've interviewed behavior people, I'm sitting there choking on my words, going, I know I'm going to use the wrong term. I'm going to use something that's out of date. People are going to come down on me like a ton of bricks because I'm not current. But that's a really good way to avoid that fear of being wrong in front of your peers and your colleagues, isn't it?
Yeah, it's expanded, it's exaggerated. That's what it is.
I love that. That's like another gem. Right, pushing you through the questions.
You have that one free.
This is great. This is like a treasure trove for me. So we've kind of talked about communicating the possibilities, not only to our colleagues and our clients. Anything that you've got in your back pocket, apart from that relationship building conversation that we had, have you got any tips of trying to bring chronic pain understanding to the people that you're working in your region? Like, so if you've got vets, rehab establishments, have you got any tools that you use to try and up their understanding of your discipline?
I suppose it's just reiteration really of it's reiteration of what chronic pain is. I think a lot of people still think that chronic pain is acute pain that's gone on longer. That's what they think it is. And you have to explain about how it's a very different phenomenon. But that just takes lots of time and lots of repetition. I mean, that's what I've been doing for years, just repeating myself. It takes a lot of repetition. And that's what learning, to some extent, that's what learning and teaching is. Some people will hear it at some stage and other people will hear it at a later stage. So you have to keep repeating things. And sometimes you have to keep repeating it. You repeat it, but in different ways so that people get it. I get that analogy. I didn't really get that other one. Or as they get older, they develop chronic pain themselves, and then they get it. You hang around long enough, all the people you were trying to persuade will develop chronic pain, and then they'll appreciate what you're talking about.
No, it's really true. Because I didn't know whether you ever kind of linked to something that you've written in the past, or whether you think that might come across as being a bit patronizing and a bit dictatorial. When you when you want to try and help someone.
That looks a bit like, oh, here's something I wrote. No, I don't do that. I tend to just try and explain it in one good way of doing it is if you're one of the things, and it's partly laziness. Well, having spent years writing a full report to the owner, and then a shorter report to the vet, one of the things you can do is write, which I've been doing more recently, is writing a letter to the vet, but saying I'm copying this to the owner, therefore I'm using much more layman's terms than I normally would. and then you can explain it all without sounding patronizing, because because you don't know what the referring vet that you're sending it to knows or cares about, in terms of, are they going, oh, that's really interesting, or whether they just go, just tell me the bottom line, which of course, when you're very busy and it's not your thing, I just want to know what you're doing, what medication you're using, what's the prognosis, that's what I want to know. And others, of course, really want, they're really interested and they want to build on what you've done and find out. So yeah, that's one way of doing it. I'm copying this into the owner, so therefore
again, that's another gem, because we get lots of therapists, so the integrative therapists external to a practice, they're trying to win favor with the vets, they're trying to prove themselves, they're trying to show their value and their competency, and find themselves writing extensive,
too much scientific language or too much foreign language. So a lot of physiotherapy language. I mean, I've got a great physiotherapist I work with. A number of times I have to go, could you just explain what it is you mean by that? And great, she explains it in great detail, but you've got to have a lot of time to to ask and then look at that and go, all right, okay, I get that. So if you rather than because that thing that new graduates do, which go, oh, well, the more nervous you are, the more scientific you speak, and the more you lose your client because they don't know what the hell you're talking about. And actually, the more you talk simply and straightforwardly and use metaphor and analogy and give people that grasp of understanding, then the better it is. So I think that is a good way of doing that and saying I'm copying this into the owner, therefore the language is more simple than I would use when I'm communicating directly with you. And then you'd have to write 2 reports, which is
and that's perfect, because life is miserable when you have loads of reports to write. I have to I've got a new passion, a new fad. There's a podcast out called Think Fast, Talk Smart, and it's wicked, and it's from a professor of Stanford. And he just gives you these little tips to do in communicating, no matter what sector you're in. Proper American. And he's the one that I keep thinking about is he always says, what, so what now? Every kind of communication with somebody is, what's the problem? So what about it? And what now? And I was like, that's great, isn't it? Anyway, that's my little passion of this week. I've done lots and lots of driving. Right, next question. Sympathetically mediated pain. Not really ever heard of it before. Can you please explain?
Yeah, it's one of those things you think, oh, I probably wish I hadn't mentioned that, because it's such a tiny thing that and of course people notice it. So we don't know if it happens in animals. My thing is, surely we would notice it. So it's been called lots of different things. That's one of the things that happens when we don't understand something. We keep giving them different names in the hope we'll understand them better. So it used to be called reflex sympathetic dystrophy, causalgia, complex partial pain syndrome, regional pain syndrome, sympathetically mediated pain. It's called sympathetically mediated, not caused by, because the sympathetics, which control the blood vessels, appear to be involved because people who have sympathetically mediated pain describe the limb, it's usually a limb, as feeling very, very cold. And that would be therefore something that's going on with the blood vessels. So it can happen in people spontaneously with no obvious cause, and it can happen secondary to a trauma. It's usually a limb, it's a particular region, and the limb feels cold and often numb. horrible, really unpleasant. The skin becomes shiny, and then the hair that grows back is often coarse and dark, and it's incredibly painful to touch, incredibly sensitive. And you think, well, I'm not going to miss that, are you? You're just not going to miss that. To be really, and I thought, does it not happen in animals? Do they need to be a certain age for the, for whatever it is? Because we don't know what's going on, so we can't say. And I do wonder whether or not, and that comes to one of the questions, which is about auto amputation later, but I wonder whether it's some of these dogs that have the traumatic fractures and things and then start to auto amputate their digits. I wonder whether that might be what's going on with them. But, it's very hard to say, because with that description, you think, well, you wouldn't miss it, would you? It's severe. No. We don't know. I mean, other people might know. They may say, yes, absolutely, we've established this in animals, but I've not heard of anyone saying we've established it without doubt that it happens in animals. But yeah, I just threw it in there as it's a possible thing, and I suspect it. I mean, that's the kind of thing that would happen. They would start auto amputating. They would, they would lick. They would pay attention to that limb.
Okay. Yeah.
A horrible kind of pain. You have to vote for a kind of pain you don't want. That's the one you don't want.
That's the one you don't want. I remember right at the beginning of getting interested in pain, I listened to a TED talk about it, and there was a girl that I think she had a fractured wrist, and no one could explain why her whole limb went, like, as you say, that shiny, cold purple. And she was only about 13 years old or something. And arduous, long journey to recovery, but she did recover. Perfect. Okay, I look after an 18-month-old patient with acral mutilation syndrome. She has had multiple digit amputations, and there are existing wounds that are currently controlled. Would you consider this nociplastic pain? Thank you very much for a brilliant lecture.
Thank you. In a way, you don't really need the term nociplastic, because you already have a name for the condition. It's a horrible condition. This syndrome seems to be genetic, happens around about a year of age, where these poor animals start chewing their toes off. It'll be a mixture. It'll certainly be a mixed pain picture, probably neuropathic and nociceptive inflammatory. It might be nociplastic. Nociplastic is a term, in a way, that we've been gifted by the International Association for the Study of Pain for all those pains we can't explain. So in humans, fibromyalgia would come under that, although they are starting to find the markers that, what a surprise, look as though it might be an immune-mediated condition. So nociplastic is those kind of pains where you can't say, well, you can't say it's definitely neuropathic, or it's definitely nociceptive, it's definitely nociceptive inflammatory, it's myofascial. That's where we can use the term nociplastic. So there's no reason why you couldn't use that, although usually it's useful when you're struggling for some other label, and obviously people like labels. They can be problematic, and you have a label for your patient in a way. Well done for keeping it going as long as this. It's a hideous condition. So yes, may well be nociplastic.
Have you noticed any correlation with trauma and chronic pain? For example, rescue ex-shelter animals are more likely to show nociplastic pain. Thank you.
Well, I don't know about nociplastic pain, but they may very well be more likely to. I think it's a hard one to say, because many animals, from any animal, any person, can show pain. Certainly we might expect people with multiple conditions to deal less well with their pain. That's not in a critical way, in a judgmental way, because if you've got multiple things happening, if you've got a microbiome that's not functioning properly, you may well be more likely to feel pain more, because you have any kind of inflammatory process that's going on. You're going to feel pain more. Stress, there's a link obviously between stress and the gut, and then there is a link between the gut and inflammation and pain. And so yes, I think it's very likely they do. I don't think I could come up with numbers or figures and say, because there are so many other things going on. But I don't think it would be unlikely that you might notice a link between animals who've been traumatized and animals who perceive their pain as being worse, but we have to be very careful with that because their pain might be very severe.
Yeah.
This comes down to this difficulty of saying, we get an animal who has pain and who has, let's say, anxiety, not unlikely, and you reduce the palpable pain, what you can feel, and what the animal's doing, and you reduce the palpable pain to nothing or almost nothing, and the animal's still showing anxiety.
Mm-hmm.
And that's when you have to go, so do they have pain that I can't feel? That is still significant enough that they're going, yeah, do you know, if you could ask me, I'd be saying this is still pretty horrible. Or are they now so sensitized to the pain, just like they might be sensitized to the sound of fireworks, that a tiny bit of pain results in a big emotional response?
Mm-hmm.
I don't know why you couldn't get sensitization to an internal aversive stimulus as you can get it to an external aversive stimulus. Why would you not be able to? And that's the difficulty. And that's when you're going, more pain relief? Or do we start down the anti-anxiety route? And that's the tricky one. And sometimes you just have to go for it. That's where things like cannabidiol can come in very useful, because that's when you might say, well, actually, this animal's been struggling a lot with everything, with its emotions, with its pain. Its endocannabinoid system may well be depleted. So this might be a good time to put in, rather than jumping for your behavior modifying drugs, this would be a good time to try cannabidiol. So yeah, short answer, wouldn't surprise me. Long answer, we don't want to assume that it's all, but we don't want to assume it's all about emotion. Obviously, it's all about emotion. We don't want to assume it's all. We don't want to stick them all on behavior modifying drugs, is what I'm saying.
Yeah, and I think the studies.
Let's see if we can find other ways of reducing their emotion without having to put them all on behavior modifying drugs, which have their place and are incredibly useful. But
Yeah,
we're overusing them big time.
Overusing them in the human sector a lot, aren't we? So that kind of covers one of the ones later on, which is talking about learning. I might jump to that now because in many ways you've touched upon it. Where is it?
The sense that can you teach them not to be frightened about, say, a hand touching them?
Yes. So is the learnt aspect of pain, I think it's been alluded to in another question, but treated by gradually widening the patient's window, e.g. dog hypersensitive to touch, you might use a soft toy to reteach the alarm parts of the pain response, that touch itself is not painful and that hands don't equate to pain. I don't see why you can't teach pain just as you do pleasure.
Yeah, so you want to reduce the pain first. So you want to reduce the palpable pain. Let's say the animal is very worried about having his ears touched, and you're pretty sure there's nothing in the ears now, there's no obvious sign of pain, and palpably you can't feel anything, but the animal's very sensitive about it. Then you can say, okay, well, maybe they have just learned. Now, in order for it to be learned, it would have to be a consistent response in the same context. Bad one day, great the next day is not a learned response. They've still got intermittent pain. So it has to be consistent. So if you have a truly learned, because owners go, oh, is it just learned now? I go, if it was learned, it wouldn't be unpredictable, because that's not learning. So it would have to be the same in the same context. But if it is, then yes, you would try and desensitize them. You would try very simply to desensitize them in the way that you're describing, approach at the lowest level that they can cope with. And then repeat and repeat until they don't care, and then you take the next level up. If they cannot deal with that, or they can deal with it one day and not another, exactly the same thing, then you might be going, maybe there is still actual pain here. So the answer is yes, but you approach it cautiously and never assume that this is all just learned and they don't have any more pain.
Amazing. That's another gem. I'm gemming out here. I like this.
Pain that you can't feel. So we have to remember. Most stuff you can't feel.
Yeah.
No,
that's another good
one. But they're limited.
Yeah, I don't think I'd put the learn response of being the persistent, consistent.
Yeah.
And I find it quite a confusing area. So I love it. Love it. Right. I'm really interested in both pain and behaviour. I'm keen to undertake the WASAVA pain certificate and hopefully set up pain clinics at my practice. Do you have any pointers for further learning on the behaviour side, as I'm unsure that I have time for a certificate MSc? Gives a shout out about what you're up to.
Good opportunity to plug, eh? Yeah, so I've been teaching chronic pain course for 15 years now. So there's a chronic pain course, which is a 4-day total, which goes into all the behavioural aspects of
Done
chronic.
it. It's good.
Thank you, Hannah. That's now in a 2-day online, 2-day in person format. The other thing that I've been offering for a while is that once you start getting into chronic pain and really assessing pain, what some people then, because I've seen them do it, is go, oh God, we need to know about behaviour now. I can't do this unless we know about behaviour. So rather than having to do a whole behaviour course, is I also offer it, this one's online, is behavioural medicine for the pain clinician course.
Ooh.
Which is a 4-day, pretty intense course where we go through behaviour but we do it from the pain angle so that you are much better, because you're going to get asked, or you're going to do this much, and then they say, well, but they're still doing this, and you go, okay. Is that behavior, or is that I haven't done enough of my pain? Or older animals, is it cognitive dysfunction? Why are they still up at night, and you're going, oh God, is it the pain, or is it cognitive dysfunction, or is it the people next door that are keeping it up? Or, the owner's saying they think that it's attention seeking. Is it attention seeking? Maybe it's attention seeking. I don't know. It's attention seeking. So that's that angle. So that's a 4-day, pretty intense course about behavioural medicine for the pain clinician. So
that's amazing. I didn't know you did that.
There you go. That's what nobody knows I do it. That's the problem.
Yeah,
so that's all on Longview CPD. So
okay, I'll go and check that out as well, because you've just hit the nail on the head. They are common problems. I had a case today. Is it pain or is it CCD? Is it pain or is it a learnt behaviour? It's so common. Love it. Another little gem. We're racing through now. How do you feel about people perusing a cause and spending available funds, leaving little to work with post? How can we navigate this? Oh, yes. So this would be, it's a contentious issue, isn't it? That we're doing huge amounts of investigatory work.
So you have to ask yourself what you're going to learn. What are you going to learn from? Are you going to learn something that's going to take you forward? So I think I possibly explained this on the lecture. But so what I'll do is unless it's a 10-year-old boxer with a painful mid-shaft bone, you go, going for investigation. There are some things that you're obviously you are going for investigation, and before we do anything else, clearly there are those things. But most of the time I will start dealing with the pain, particularly if we have an expanded pain field. If we've got an expanded pain field, all bets are off about what might be going on. Mm-hmm. You need to, and this goes to the next question, you need to find out, if you've got expanded and exaggerated pain, you need to shrink the pain field in order to localize the pain, in order to classify the pain. If you can classify the pain into neuropathic, nociceptive, inflammatory, myofascial, then you know what to treat it with. There's a range of things within that group that you start treating them with. So I go, we're not doing anything until we've tried to wind this pain field down. If I fail to wind the pain field down, we're going for investigation. If I wind the pain field down and whatever, we're doing well, and the pain breaks through, we're going for investigation. Mm-hmm. If we're doing really well and I take them off the medication, start to take them off, and the pain breaks through, we're going for investigation, because there is something there going, hello, you need to be looking for me. Still might not find anything, but those are my justifications. So I try and hold people back so that we can at least say, look, if I send you now, what are they going to be looking for? There's like this amount to look at. What I want to be able to do is go, okay, it's a spine thing, or it's central, therefore, and it's around about here, therefore I'm sending you to a neurologist, and I'll tell them it's around about here, and then they can obviously do their stuff. Or I'm going, oh, hip. It seems to be a hip thing. Right, you're going to an orthopedic surgeon. So that's how I kind of slow them down a bit. Obviously, I will say to them, if you really, really want to do something beforehand, we'll do it. But it's an anesthetic, which they often don't realise. And quite often these chronic pain patients get worse when they are anaesthetised, positioned. I think nobody's doing anything wrong. It's about the positioning for a long period of time. They can't adjust. And then with the best will in the world, when they are moved, if you're painful, you would normally guard, but you can't do that when you're Eastized, so you flop. Sometimes it's completely curative. I have had the odd animal who's completely cured by an anesthetic, which is fantastic, because I presume some kind of deep muscle spasm is probably relieved, but quite often they're made worse. So they need to understand all of that. Go, oh, okay. So it's not about you saying we're not doing it, but it's about saying we want to optimize your money and your funds, and we want to minimize the stress on your patient. So we want to do it once, and then lucky they could go to neurology. If neurology don't find something, can you check the hips? But that you don't always have that luxury. So we want to optimize where they're going, what they're getting, what they're getting.
Again, that's another really, it's the way that you phrase it is another gem. We need to wind it back down, etc. Deb, who is listening in, we had our tea and chat yesterday, and she was talking about the lecture about dental pain, and that was at the Chronic Pain Symposium, and she was fascinated. She's a canine professional, if I believe correctly, and we were talking about exactly that, the handling under the anaesthetic for the investigations, whether it's actually going to cause more harm. If you hear a barking in the background, it's because it's the Moroccan street puppy outside the door. And this is my mother's living room, and it's got a white carpet. She's desperate to come in here, but it's a no. It's no. So hopefully she'll stop barking in a bit. Right. Next thing is, there are so many modalities available to us now. How do you choose where to start beyond anti-inflammatories?
Yes. So that is where you have to come down to your classification. What's causing the pain? If you have an expanded, exaggerated pain field, then you have a choice. You have the anticonvulsant group. So we go through all this in the course, but anticonvulsant group, which are the gabapentinoids and topiramate, essentially. There are others. You have the NMDA receptor antagonists, so memantine, amantadine, ketamine. You have the tricyclic antidepressants, amitriptyline, imipramine, nortriptyline, not clomipramine. And those are your mainstays for winding down an expanded pain field. It's not to say nothing else can, not to say non-steroidals can't, if they absolutely address the right pain. But that's where you start. If you know you've got inflammatory pain, then obviously you're going to use an anti-inflammatory or either non-steroidal or steroidal. If you have muscle pain, then you're going to use physiotherapy, acupuncture, laser. So you need to localize your pain. Otherwise, it just becomes random polypharmacy. You want to know as far as possible what you are treating. And that comes down to what you feel under your fingers. Yes, what you see in imaging, but imaging doesn't always tell you what the problem is. It just tells you what the problem you can see is.
Yeah. And what about, because there's a lot of practices that are now bringing on board other therapies. I think their choice of modalities, they're possibly also bringing in the acupuncture, the laser therapy, maybe TENS. A lot of practices are bringing in the more physiotherapeutic modalities. Any advice?
Be sensible. Don't buy such an expensive laser that you've got to use it on everything. Target. Did I just say that out loud? Target. Target your treatment. Again, it comes back to, what am I treating? Does this animal need help with its movement and muscle pain? Does it not cope very well with medications? Sometimes that's a reason for choosing physical treatments, but not the only, and shouldn't be the first treatment. So usually we want medication to wind stuff down quickly. That's usually what we want to do. And then you can start bringing in the physical treatments to maybe limit what you're doing medically and build up. And you've got to, what is my outcome measure? This is winding down the pain. This is targeting this kind of pain. Right. But now we've got weak legs, so we need to do physiotherapy. And so we need to do physiotherapy to build that up. Owners always see those things as more positive than medicines. But medicines are, of course, important because you can't do the physiotherapy if they're too painful. So it's got to avoid random treatments just because they're available. Just because you're a hammer, the whole world's a nail. You've got to target what it is you've got. Otherwise, owners get fed up. And what you've got to, if you tell yourself, and most importantly, the owner, what your outcome measures are. This is what I expect to happen with this treatment. If you can't say what you expect to happen with the treatment, then don't do it.
Yeah. That's a really good point.
Oh, I don't know. Just because we've got one. Why am I doing physiotherapy? Well, because, they said they wanted it. Well, but what do you want to achieve by it? So have your outcome measures, whether they're behavioral, physical, is it muscle strength, is it muscle weight? What is your outcome measure? Where in your toolbox? And we are fantastically privileged. We can do anything we like as long as we can justify it. We can do anything we like. We can have bit this, bit that, whatever, but you've got to be able to justify it.
Yeah.
And justify it by saying this animal's back legs are weak, therefore we're going to do physiotherapy. And you need to know what that physiotherapy consists of. Just send them to a physiotherapist. You should be involved with what the physiotherapist is going to do and actually say, this is what I want to improve this patient's core strength. I want to improve their back leg weakness. I want to, what is it you want to achieve? Not just go and have some physiotherapy. That's not what you should be doing with physiotherapists. They don't like, well, some of them might, but certainly the ones I work with really like to be told, this is what I want to achieve with this patient. They want to work with you mostly, not sit in a corner doing their own thing.
No.
At least they shouldn't. They should be wanting to work with you to achieve what you want to achieve. I want this dog to be able to walk further, or what is it you want to be able to jump in and out of the car? Probably not. What is it you want to achieve? So that's the thing. If you don't know why you're doing something, take a step back and go, what are my outcome measures? Is this going to achieve one of my outcome measures? Do I think it's going to achieve one of my outcome measures? And make that commitment to the owner and saying, this is what I expect this to achieve. And then they can call you out on that. Fine. They can call you out on that and say, I don't think this is working. And you go, oh, okay, good. Thank you for telling me that. Let's review then. Why isn't it working? Is it because I was wrong? And that's absolutely fine. You can say you're wrong. I was wrong in that judgment. So what is it we do need? You can say mistaken if you don't like the word wrong. Mistaken in that. So let's find that out. Or is it that that particular way of doing it isn't working for your patient, or they're very anxious about going into that. So maybe let's do some DIY stuff, So think about your outcome measures. What is it you're trying to achieve? And then you can start picking your modalities and then reviewing. That's like your own audit per patient. Have I achieved what I said I wanted to achieve? If not, what are we doing? Why are we doing this? Why is this owner coming back week after week for hydrotherapy or whatever, and we're not achieving what we want to achieve?
I think that's such a...
coming back because they perceive physio and hydro and laser as all positive things. But if they're not achieving what you want to achieve, they're just using up their insurance money. They might be having a nice chat and all the rest of it, and it's fine as long as they've got endless pots of money and the dog, cat, welfare isn't compromised and isn't having a stressful time. As long as you're still doing the thing that needs to be done somewhere else.
I really like that. Again, there's been a load of gems in that one. I'm going to rewind just to the beginning of your kind of explanation. Is you did say, medications have the capacity to work faster. And I think there is, I'm going to be really outrageous here. Sometimes I think because there's not the interdisciplinary kind of communication going, I think you might find the external therapists having had to work on their own quite a lot. They haven't had that discussion. They think their tools are also quite quick acting. And I think there's sometimes conflict of who's going to initiate the necessary change. And I love the fact that you boldly said, look, come on, medications work quick. Let's work together on this. We'll start, dialing down the pain. And I'm wanting you to come in with all these other modalities, these functions. But I do think that that's quite a jam point. I see quite a lot. I hear quite a lot. And it boils down to not communicating and sharing your skills and sharing your knowledge and sharing your experience and working comfortably with each other rather than being slightly threatened by each other, isn't it?
You need to make sure that you're doing this in order to facilitate that.
Yeah,
we're doing the medicines in order to facilitate the other physical stuff.
Yeah, definitely.
You're relieved when you go, the medicine's only part of it. We'll do a lot of physical stuff later, and they go, oh, right, that's good. That's good. Yeah, good. As long as we know we're going to do that stuff. The odd one, you start with physical stuff because that's an appropriate thing to do. But mostly it's medicines to start with. But not always. It's got to be
no.
Got to be flexible and agile.
Flexible and agile. Now I'm conscious of your time, so we're going to leave this last question, and it is a bit of a potent one, and I've kind of skipped it until the last. have you had cases where you can't control their pain? And I'm not asking this question last to kind of end on a bad note or trip you up or anything, but I think expectations and stuff. Have you ever had cases where you've done everything you can and you haven't?
Yeah. What I'll say to my clients is when they go out, I say, look, you're going to get this report. It's going to sound really bad because there's a lot of pain and they can't stay like this. But I said it's very unusual that we can't make any inroads, but we can't always. Mostly we make inroads and they're reassured by that. But of course you can't sort them all. But sometimes you run out of time. You can't get them better fast enough before their suffering becomes is too bad. Sometimes, of course, it's inevitable because they've got cancer, and that's what they're you run out of time with that, of course. And other times they can't tolerate any of the medications, nothing they tolerate, and then they won't tolerate any of the physical stuff, or the physical stuff isn't working. And sometimes you just don't seem to be getting a handle on it, and that, of course, is natural. And it's important that people know that, of course, we don't get it. We don't always manage to sort it. We don't manage to sort it, and that's very important to know. But it's also very important to know that most of the time we do improve things, and a lot of the time we do improve things massively. Help the owners understand, and the owners understand, and then the owners get really good at spotting when the pain, because they have the outcome measures, they have the things that they now know are the signals that the animal's not coping with their pain, and they get in touch with you and go, oh, they're doing that thing I didn't know was anything to do with pain. They're doing that thing. Can we, they need to come in. And that's great because that is that awful word, which I hate, empowering for the owner. It makes them feel more confident, and they can get in and help their pet's pain really quickly, which is great.
I love that. That's such a good, positive endpoint because, as you say, if it isn't for the caregivers, they won't bring the dogs or the cats in the first place. If they don't notice and they can't monitor, then we can't continue to develop our skills and our services. So it's a very, very good endpoint. I'm conscious of time. I am also very aware that I'm beginning to look like an anemic ghost with sunburn. Have you noticed? My lighting tonight's horrendous. And before it gets any darker and I start disappearing, thank you so much, Sam. Dear, me personally, and I mean this properly, I'm not doing this because I'm on camera. Every time I listen to you, I learn so much. And what you've done this evening has been such a kind of sack of knowledge filler for me. I've really, really enjoyed it. I'm sure everybody else will. As you know, the way that the world is, people watch things on record now. There will be many more people that will watch this. We've also got plans to try and snippet it up, start sharing it on different platforms, etc., to try and get the word out there as much as possible. So thank you for your time. We will use it very, very wisely. Everybody's saying thank you we're streaming to another platform, so you can't see it in the comments here, but everybody's saying thank you on the other platform. So thank you for your time.
Pleasure.
And it's a good night from us, guys. So take care of yourselves.
Okay, bye.